My pleasure to introduce a friend, Professor Carlos Simon. He's a professor of obstetrics and gynecology at University of Valencia. And he's also an adjunct clinical professor at Stanford and at Baylor in the US. For many years, he's been scientific director of the EV research program and their spin-off companies. Carlos is really the ultimate clinician scientist. He's published over 400 papers. He has an H index of 65, and he's spent years looking at endometrial receptivity. So I'm very interested to hear about the symphony today, Carlos.
Thank you, Bob. It's my pleasure to be here. Thank you for your very nice introduction. And Seb asked me to put the whole context in the symphony. So I'm going to use this analogy to go through and explain you what is the relationship between the embryo and the maternal endometrium. First, let me just disclose that I am the scientific director of this company that is commercializing one of the products that I'm going to tell you about, so you have to know that. And let me just go directly to the concert hall where the symphony will be performed, which is basically this. And as you see here, the question and the point is not only how this symphony is being performed, that we are knowing more and more about the way that this could be done. And Franco Di Maggio is an excellent example, his presentation of how deep the knowledge is getting on that. But also I would like just to take your attention on the when, not only how, but also when. And just putting the point on the personalization of the endometrial factor that is also important to understand the embryonic implantation. Because until now we have one of the musicians, it's in jail, which is the embryo. We transfer the embryo and we expect that the endometrium will behave the same in all of our patients. And this is just the contrary that we used to do every time that we treat our patients. We don't give the same dosage of gonadotrophins. We don't treat all the oocytes the same. We do ICSI or IVF. We do personalized medicine. But when it arrives to the embryo transfer, we always transfer the embryo at the same moment. I will try to convince you in this presentation that in at least 25% of your patients, what you are going to see sometimes is that the window of implantation is delayed, sometimes is advanced, and sometimes is narrow that you think. And this is the concept of to understand personalization going also to the endometrial factor. So for that, let me just also make another challenging point, which is we used to believe that this is the ultimate analysis, the ultimate diagnosis of the endometrial factor, hysteroscopy. Consider from now on that this is not just the ultimate. Hysteroscopy is something that is useful in some cases, but there are very nice publications. There are randomized clinical trials published that the value of hysteroscopy could be limited if there is nothing else to look for that to find it in the ultrasound. So let me just put Google Glasses for that. It's not just the morphology. Anatomy is a long time going through. We have to keep in mind that there are other ways to see the endometrial factor. And those ways are just not only morphological and not only ultrasound that we are using to help us, but also there is another way. There is other ways, which is the transcriptomics, as we do in oncology. I mean, oncologists do in oncology, that they guide them to make the decisions. We have also secretomics, the production of proteins that can help us to understand the receptivity status. There are also stem cells that they are helping us to try to solve problems as Asherman syndrome that we cannot do in many cases more than just to do another hysteroscopy and put another IUD inside. And you know that in 50% of cases, nothing works. And also, we are starting to understand the microbiota And I invite you to read in the December issue we have in the American Journal of Obstetrics and Gynecology, trying to understand the human uterine microbiota that is there is different from the vaginal microbiota and may have an implication in the reproductive outcome. So all of this must be considered together if we really want to understand the endometrial factor. No single factor will last. But let me start with the transcriptomics. Let me start just to making the starting point from this test to understand the window of implantation. This is just, you cannot read that, but this is just for you to make an idea of the work developed in the last decade to understand the transcriptomic of the human endometrium. And those colors, they come from our own lab, and you can see that in our endometrial database. And from this information, we just obtained, and we just got the signature, the transcriptomic signature of endometrial receptivity. And we published this in 2011. This signature is composed by these 238 genes. You can take note of that, but it's published, so not to worry. This is just, you can see here what is the fold change of these genes. You can see the gene name. This is published since 2012. And the relevance is not only the signature. The relevance is the development from that. So nowadays, we start as an array, but nowadays we are doing with next generation sequencing, using either the Illumina platform or the Life Technology platform. And with that, we are able to couple this to a bioinformatic predictor, a classificator, and finally, what we just got is the diagnosis of whether this endometrium obtained in this patient under this specific hormonal treatment is receptive or not. Typically, we obtain the sample at the moment that we used to transfer our embryos, which is typically in an HRT protocol after 5 days of progesterone, or in a natural cycle after 7 days after the LH peak. And by doing this, we can analyze the endometrium, and after that, we will end up having the diagnosis whether this endometrial sample is pre-receptive, it's receptive, or is post-receptive. And if so, whether we need to add 1 or 2 more days of progesterone, or we may need to do the transfer before that we have done the endometrial biopsy because the window of implantation is not there yet. This is the main concept of this, making things easier. And because we will know where is the window of implantation, the whole point here is to move from a regular embryo transfer that we always do when we transfer, when we just thaw the embryo, or when we have the embryo ready, in order to just move to a personalized embryo transfer, which can range from 3 days of progesterone administration to 7 days of progesterone administration, considering that we are transferring a blastocyst. If we transfer at day 3, of course, you have to make the synchronization. So this is the concept of a personalized embryo transfer after we know where is the receptive status of the endometrium. So there is already many publications, more than 12 publications, prospective, retrospective, about the use of this endometrial receptivity analysis. As you have seen, we published where the discovery of this signature. We also show what is the accuracy and consistency compared to the Noyes criteria. We also show the comparison with other colleagues in the United States with other morphological techniques. And we try to put in the context of several medical conditions, such as recurrent implantation failure, such as the endometriosis, such as obesity, and even we prove that with different hormonal protocols to see how they stand. So we have done this in patients with oral contraceptive for cycle scheduling, with GnRH agonist triggering, with even administering ACG in the endometrial cavity. And finally, we have looked for different ethnicities differences, and we do not see any different. At least we have tried the Indian population against the Caucasian population. So Just let me give you some few examples of that, and going from case report to a randomized clinical trial. So this is just one case that we published together with Dr. Pellicer. It was 2 years ago, in which this is the title, What a Difference Today Makes Personalized Embryo Transfer, a case report and pilot study. In this case, which is a very frequent one, we just got, in fact, he got this patient. We just have this patient that she came with 2 previous IVF failures, and she was 39, and he suggests the patient just to go for PGS. The patient does not want to, so she continued with the regular thing that we used to do. So try IVF with another flavors, either with fresh day 5 embryos, with deferred day 5 embryos in natural cycle, and the patient was already 41, already 4 previous failures, so the patient was counseled to go to ovum donation, and 3 ovum donation cycles were performed, again trying day 3 blastocyst, HRT cycles, natural cycles, and nothing works. At that moment, the ERA test became available, and the patient was counseled to have this test, and when we did the test at the regular moment that we used to transfer the embryos, after 5 days of progesterone, it shows that it was pre-receptive, and being receptive 2 days later. We repeat that, and in fact, it was after 7 days. So the transfer next cycle was, the patient was suggested to go for this personalized embryo transfer with 2 blastocysts. There was no way to convince this patient to transfer 1 embryo after all of this. And the patient became pregnant just at the first attempt, and she has successful twin pregnancy. So we have been using this for a long time in patients with recurrent implantation failure. We suggest to work with difficult patients, and this is what we have done. Let me show you another example of the symphony incomplete. This is something that I think we will all agree, which is an elevation of progesterone at the day of HCG is a bad prognosis, and I think that nobody will go ahead with the transfer if you have, I don't know, more than 2 nanograms of progesterone at the day of HCG, or in our case, 1.5 nanograms. So what happens here, basically, is that this symphony is incomplete, and we have double-checked that with our system. Once you have this progesterone elevation at the day of HCG, what is going on there, basically, is that the window is advanced. And if you transfer the embryo, we know that the results are going to be poor. So you freeze your embryos, transfer next cycle, and nothing happens. The opposite can apply to the other way around. These are data from Richard Scott, and the endpoint is if you have a blastocyst that achieves the blastocyst stage at day 6, you better freeze your embryo and transfer next cycle, because it's not going to perform as well as a day 5 blastocyst. And in fact, we are doing this also very successful, as he shows from the beginning. And what happens in this case is just the opposite. By having a delay embryonic development is the embryo that is missing the window, and then the symphony does not work. And so this is another reason for that. For instance, in obesity, and this is a paper coming now in fertility and sterility, in obesity, we have done this in collaboration with Stanford and Baylor. If we divided the patients according to the BMI, what we have seen is that basically, as BMI increases, the percentage of non-receptive endometrium also increases. And in those patients with morbidly obese, these non-receptive, they go up to more than 40% or 45% of cases. So this is real, and this is happening on that. Until now, we have analyzed more than 12,000 patients. This type of patients that we have been always said that try with your most difficult patients. And by doing so, we have repeated those for the last 4 years, those results in which we have about this 25–30% of non-receptive endometrium at the moment that we thought that the window was there. And going from these non-receptive patients, the majority of them, they are pre-receptive. They need 1 or 2 more days of progesterone. And we have this 12% that they were post-receptive, in which those patients, they need either 4 or even less days of progesterone. And this is the recollection that we have done until now, retrospectively. Now, the thing is, we want to obtain high-quality data. We want to work in evidence-based medicine. In order to do that, the only way is just to go for randomized clinical trials. And this is what we started at the very moment that we have the test. So what I'm going to present you is the interim study of this randomized, prospective, randomized, multicenter, international control trial, in which basically we just jump from difficult patients, patients with recurrent implantation failure of endometrial origin, we jump to patients undergoing IVF-ICSI with their own oocytes, first cycles, coming to the clinic as they enter in the first appointment, the age between less than 37, BMI between 18.5 and 30, normal ovarian reserve, blastocyst transfer, and PGS was not an inclusion criteria, neither an exclusion criteria. What you're going to see is just pure endometrial factor. In all of these studies, you can understand the difficulty to do a randomized study, so if we put together different factors, it was almost impossible. So this was planned only for the endometrial factor at this moment. Also, of course, any endometrial pathology was operated previously or was ruled out. The objective of this study was basically to assess whether personalized embryo transfer guided by endometrial receptivity analysis improves or make any difference in terms of reproductive outcome compared to regular fresh embryo transfer or defer embryo transfer, all frozen embryos and then transfer them back, in infertile women undergoing IVF. So the issue is quite simple. We have to include those two groups because you know that the discussion is getting here, whether fresh or all frozen embryos. So in order to compare what could be the efficiency of the diagnostic system that we are just trying to improve, on that we have to include these two groups here. So again, we are ending in patients with this inclusion criteria having a blastocyst transfer in which they can go for a fresh embryo transfer, in which basically during the cycle we obtain the eggs, fertilize them, and transfer the embryo at the blastocyst stage, as we routinely do, or they can be randomized to defer embryo transfer, in which all embryos of this patient are frozen, and in the next cycle we just treat them with an HRT protocol, just estradiol, then progesterone, and we transfer the embryos when they must be transferred. Understand that this is a randomized, so centers worldwide, they think that they transfer the embryos at the right moment, and you will see the differences. And finally, with this, they transfer the thaw embryos in an HRT, or the third arm of the study is this personalized embryo transfer, in which we did all embryos frozen, we did the ERA test on the patient, and finally, with this information, we transferred the embryos in an HRT protocol according to the day or even the hour that the test indicates to do it. This was the study design. This study was first, we sent it to Lancet for review in 2012. once we pass this is a review service, nothing else but help us to improve the trial, the design. Then the trial started in October 13, and we agree with the ethical committee that the interim outcome will be evaluated when we pass halfway of the study, and must be evaluated without looking for the first outcome. The first outcome of this study are live births, but they allow us to do for the surrogate markers, which are pregnancy rates, implantation rates, ongoing pregnancy rate, pregnancy losses. But watching this in the interim, we will know whether we can continue or not, and this could be communicated, and this is what I'm going to do now here. So at this time, in 2016, April, we passed the interim, and we have these 117, 122, 170 patients included in this, in the 3 arms of the study, and this is just the RCTs sites that enter initially, that at the moment of the interim study, 12 sites worldwide, and this is the actual sites that they are just finishing the study, that it will be complete with 60 more patients recruited. So I hope that it will be completely finished by December, January, but we have to wait until the last baby will be born. So maybe at the end of this year, of the next year, will be the moment for the publication. So these are the results of the interim study. Take it as the interim study. So we have, this is the number of patients recruited. These were the dropouts, which goes for 32% approximately. Those are the patients analyzed. The age and BMI of the patients were similar. The progesterone levels that we have in the 3 groups, as you can see, it could be statistically significant higher in the personalized embryo transfer, but you see that they were 1.1 versus 0.7. All of them will be considered within the level of transfer. Embryo transfer was performed in all of these patients. Keep in mind that this group has less transfer because it costs more time to achieve the moment of the transfer, and the numbers of embryo transfer was similar with no differences among the groups, 1.7, 1.8. And these were the results. First, what we saw was a statistically significant elevation of the pregnancy rate in the personalized embryo transfer group compared to fresh and deferred embryo transfer. The first thing that you can see here is that there was no difference in fresh or all frozen. And the second, we have this elevation, which goes up to 25%, 24 something, in the personalized embryo transfer, and at this moment of the interim reaches statistical significance. Implantation rate, it was a trend towards an increase, as you see, in this group versus the other groups. However, it was not significant at this moment. Biochemical pregnancies, ectopic, and clinical miscarriages, there was not statistically significant among the 3 groups. And ongoing pregnancy, although you can see the trend, is not significant yet. And interestingly, twins and singletons shows a trend just to the opposite. As you can see here, there is a lower twin rate in the personalized embryo transfer group versus the fresh and frozen, although still not significant. We are in the interim study again. So we have one statistically significant thing here, which is pregnancy rate, and the rest of parameters are just trends. And of course, this means that we have to continue and we have to finish the study. The consequence here is that we have this 24.9% increase in pregnancy rate. Again, the first outcome, which is live birth, has not been investigated yet because physically it's not possible to do it in the middle of a study. But those are the surrogate. Now, this is the 25% increase of pregnancy rate. Why this increase, where this increase come from. So we just went to find out what was the reason. So in our series, in the personalized embryo transfer group, we find that 7 patients out of 49, they were non-receptive at that moment. And so this accounts for 14% of our patients. Those patients, all of these 7, became pregnant after personalized embryo transfer. It means that the weight of the pregnancy rate in this group was 16.6%, which was that basically come from this switch of the window of implantation due to the diagnostic, because all of these patients were non-receptive at that moment. But what happens with the 8.3% left? Okay, this is even more interesting. When we compare, because with the fresh embryo transfer, you cannot compare anything because it's fresh and you don't know what is going on there. But when we compare the deferred embryo transfer versus personalized embryo transfer, and we do statistics that we like to do very much in terms of the hours of progesterone at the embryo transfer, you see that the mean hours that the patients receive progesterone was quite similar. Okay, the deviation here was less, but was quite similar. So when we put all of this together, it looks like, yes, the mean is similar, but if we apply this Levine test to homogenize our sample, it shows that we have an important difference in terms of the range of the hours that the patients with the deferred embryo transfer, that several groups all over the world, they may think that this is 5 days, 6 days, 4 days, or even if they think that these 5 days, they are being transferred in other moments, maybe for logistic reasons. But at the end of the day, we found that there was a deviation of 82 hours. This is more than 3 days. So in this group that we think that we transferred the embryo at the same time, there was a deviation from progesterone plus 4 up to progesterone plus 6.5. Whereas in the group of personalized embryo transfer that we even said you have to do it on that moment, there was a deviation of 18 hours because some doctors did it in the morning, some in the afternoon. So this difference, we believe that this can account for the other 8.3%, and we call them clinical inaccuracy. And the point of this is just to take seriously the endometrial factor and to look for that even when we believe that this is a hormonal replacement therapy and we can transfer them, just we have to do it with a certain criteria at that moment. So in conclusion, what I want to bring here is that the concept of personalized embryo transfer guided by the endometrial receptivity analysis is associated with significant improvement in the reproductive outcome in terms of pregnancy rate and trend towards increased implantation rate and ongoing pregnancy rate in those cases versus fresh or deferred embryo transfer. And in the light of our data, we have to finish this randomized clinical trial, and if so, it will be considered that the personalization of the endometrial factor using this test should be considered in the diagnostic workup for the infertile couple, even in the first appointment. And having this in mind, synchronization is crucial. And in addition to synchronization, there are other 2 main important points that you have to consider when you transfer your embryos. The other is synchronization, and the last one is synchronization. So please keep this in mind because really it works. And I just want to acknowledge that this is the work of a team devoted to do those analyses and working in the lab together with the persons that are just providing all the logistics and all the support and for the randomized clinical trials worldwide, and the work for this company that has been developed with those reproductive tests offering this worldwide. Thank you very much for your attention.